热情介绍。我呢就是说，因为我没有在呃中文的条件下学过医，所以这个 delivery 呢，就是我很抱歉，我只能用英文。但是待一会儿我们要有问题的话，我完全可以用中文，还有 mixed with English，然后这样我们就是可以。所以我就用英文做我的报告。So good afternoon, everybody. So it's a real pleasure and honor for me to have this opportunity to present here. I grew up in mainland, so from very early on childhood, I have always admired the culture and the tradition of Taiwan. So this is truly a special opportunity for me to present here and also to experience some of the culture here. So today I'm going to focus on the utilization of combination immune checkpoint therapy for renal cell carcinoma. In the interest of time, I understand I have 25 minutes of presentation time. Sorry, maybe I can just use the arrow here. Okay, so here are my disclosures. So this slide basically summarizes the timeline of approved therapies for renal cell carcinoma. As you can tell, there are, in general, 3 periods of development for renal cell therapy development. So the first period of time was in the 1990s. So at that time, we only had cytokine therapy available. Following that, during the next decade, from about 2005 to 2015, we have an array of target therapy agents developed for renal cell carcinoma. These include tyrosine kinase inhibitors, mTOR inhibitors, and also anti-VEGF antibody. Is it okay if I use the mouse here? So, and then after that, we basically entered a new era of immune checkpoint therapy development. So this was started with a development of nivolumab as a second-line therapy for renal cell carcinoma, followed by 3 combination IO therapy, including the combination of nivolumab plus ipilimumab, or the combination of axitinib plus either pembrolizumab or evolumab. And this is basically the scientific rationale for using immune checkpoint therapy for different types of tumors. I don't think I need to get into any details of this because everybody knows this quite well these days. So as mentioned, in the interest of time, I will only summarize the phase 3 trial data for immune checkpoint therapy for renal cell carcinoma. This is the general scientific principle for the design of combination immune checkpoint therapy for renal cell carcinoma. So basically, for patients with treatment-naive metastatic renal cell carcinoma, they were randomized into 2 groups. The first group include either IO plus IO combination therapy, or IO plus anti-VEGF therapy, as compared to sunitinib, which is a known first-line target therapy agent for renal cell carcinoma. So far, there are 4 completed phase 3 trials of immune checkpoint therapy combination therapy as first-line therapy for metastatic renal cell carcinoma. These include, the first one was CheckMate 214, which compares nivolumab plus ipilimumab versus sunitinib. The second trial was Emotion 151, which involves testing of atezolizumab plus bevacizumab versus sunitinib. The third one was Javelin 101, which compares evolumab plus axitinib versus sunitinib. The fourth one was pembrolizumab plus axitinib versus sunitinib. So among these 4 trials, 3 actually resulted in FDA-approved therapies as first-line therapy for metastatic renal cell carcinoma. That's the CheckMate 214, which is nivo plus ipi, Javelin 101, which is evolumab plus axitinib, and a keynote 426, which is pembrolizumab plus axitinib. There are also 3 ongoing phase 3 trials of immune checkpoint inhibitor plus anti-VEGF agents as first-line therapy for metastatic renal cell carcinoma. So the first one was the study 307, which compared pembrolizumab plus lenvatinib versus lenvatinib plus everolimus versus sunitinib. And the second one was the CheckMate 9er study, which compares versus sunitinib, and also the Cosmic 313 trial, which compared cabozantinib plus nivolumab plus ipilimumab, which is a triple combination therapy, versus placebo plus the double combination of nivolumab plus ipilimumab. As I mentioned, CheckMate 214 was the first phase 3 clinical trial for patients with treatment-naive clear cell renal cell carcinoma. And these patients were randomized and stratified according to IMDC prognostic scores, which is in the favorable risk, intermediate risk, and poor risk, and also stratified by region, including US, Canada plus Europe versus the rest of the world. So these patients were randomized in a one-to-one fashion into 2 arms. In the first arm, patients were treated with nivolumab at 3 plus ipilimumab of 1 milligram per kg every 3 weeks, followed by nivolumab for every 2 weeks. In the second arm, the patients was treated with sutent or sunitinib at 50 milligram, 4 weeks on and 2 weeks off. This patient was treated until disease progression or unacceptable toxicities. And here is the survival data. As you can tell, for the sunitinib group, which is the dark line here, and the median overall survival was 38 months. For the nivo plus EP group, the mean overall survival has not been reached yet. But clearly you can see separation between these 2 lines, which means patients treated with nivolumab plus ipilimumab did much better as compared to patients treated with sunitinib. And here is the overall survival data stratified by IMDC risks. For patients with intermediate poor risk, median overall survival was about 27 months as compared to non-reached in the nivo plus EP group. For the patients with favorable risks, these 2 lines actually got merged together. And neither of these groups actually reached median overall survival. However, interestingly, sunitinib, the line for sunitinib actually is above nivolumab, so suggesting these patients actually did slightly better. Of course, the p-value is not significant. When we look at the progression-free survival of all the patients treated, there is no difference between the sunitinib group versus the nivolumab plus ipilimumab group. When we separate the progress-free survival into intermediate poor risk versus favorable risk, as you can tell, in the intermediate poor risk group, there is no difference between the PFS. In the favorable risk group, now you can see clearly that the sunitinib group actually has longer PFS of 20 months versus 14 months in the nivo plus EP group. However, the p-value here is not significant. If you look at the response rate, so in all patients, the response rate in the nivo plus EP group was 41%. But more importantly, if you look at the complete response, it's 10.5%. And that's in the nivo plus EP group. In the sunitinib group, the overall response rate was 34%, with only about 2% of complete response rate. In the intermediate/poor risk group, the response rate for nivo EP was 42%, and the complete response rate was 11%. In the sunitinib group, the overall response rate was 29%, with only about 1% of complete response rate. When you look at the favorable risk groups, the response rate for nivo plus EP was 39%, including 8% of complete response. But in the sunitinib group, the response rate actually reversed. So it was 50% with 4% of complete response. Of course, the p-value here is still not significant. What's more important to me, I think, is the complete response rate. If you look at the IO-treated patients, most of the patients with complete response actually had ongoing complete response. Almost 90% of them, once you achieve complete response, they will maintain complete response. Whereas in the sunitinib treated group, only about 60% of patients with ongoing complete response. Of course, this is a very small number. So based upon the traditional cytokine therapy with high-dose IL-2 therapy, so in patients who suffer loss of toxicity and they have an overall complete response rate of about 6 to 7%, this is actually very significant. This suggests, as you know, in the high-dose IL-2 treated patients, these patients were basically cured, most of the patients. So this would promote us to ask the question whether these IO-treated complete responders actually are patients who are cured. So that remains to be seen, but it's certainly very encouraging at this time. When we compare the toxicities between the nivo-EP group and the sunitinib group, it's actually quite surprising. So as you can tell here, the sunitinib group actually looks like it has more toxicity, which is very, different from what we expected. But most of these toxicities by sunitinib was due to vascular problems such as hypertension, or blood or lymphatic system problems such as pancytopenia, and but very little of them actually had the immune-induced toxicity, as manifested by endocrine problems, GI problems, hepatobiliary problems. So this is more, it looks like the IO combination toxicities were more on the immune-mediated toxicity, whereas the Sutent or sunitinib side effects were more due to the traditional cardiovascular events and also GI events such as diarrhea. The other important aspect of this CheckMate 214 trial is the treatment-free survival. So if you compare the patients who were treated in the intermediate and the poor risk group, who were treated with IO therapy or sunitinib, who discontinued protocol therapy. So as you can tell, for the nivo plus EP treated patients, at 18 months, 20% of these patients actually did not need a second-line therapy, as opposed to only 6% of patients in the sunitinib group. And at 24 months, the separation is still very similar. 19% of patients treated with nivo plus EP didn't need additional therapy, whereas only 6% of patients treated with sunitinib actually needed additional therapy. So that's IO-IO combination. I'm going to discuss about the combination with anti-PD-1 or anti-PD-L1 plus VEGF pathway blockade. And this is the rationale for combining immune checkpoint therapy agents with VEGF inhibitors. So basically, this is the cycle of tumor cell killing. As you know, tumor cells will have to release tumor antigens, and it will be captured and presented by antigen-presenting cells. And these antigen-presenting cells will move into lymph nodes and activate T cells there. The T cells will then traffic into tumors and then kill tumor cells. So these cycles will go on and on. But it has been shown by multiple publications that VEGF inhibitors actually can promote T cell priming and activation via dendritic cells maturation. In addition, Anti-VEGF agents can normalize the tumor vasculature for increased T-cell tumor infiltration. And after that, this VEGF agents actually can establish a more immune permissive tumor microenvironment by decreasing MDSCs and Treg populations. These are two negative regulators for tumor immune response. And because of that, there are multiple trials either completed or ongoing by combining IO therapy and anti-VEGF agents. So the first one, by combining these two, include is the Keynote 426 trial with pembrolizumab plus axitinib. This is in newly diagnosed advanced renal cell carcinoma. This is the trial design. Basically, these patients, again, were stratified according to IMDC scores and also regions. They were randomized 1-to-1, treated with either pembrolizumab plus axitinib versus sunitinib. And this is the survival data. So as you can tell, neither group actually reached the median overall survival yet. However, clearly, the blue-green line represent pembrolizumab plus axitinib. So this group of patients actually did much better as compared to the group treated with sunitinib. Oh. Very sorry. Looks like we have some technical problem. You know, I'm so impressed by Taiwan. Everything here looks perfect. From the traffic to, you know, amazing people here. This is the first little problem I ever experienced. Okay. Okay. 谢谢. So I will try to speed up, but I bargain for some additional time. So anyway, so if you look at the response data, so as you can tell, in the pembrolizumab plus axitinib group, the response rate was 59% as compared to 36% in the sunitinib group. And sorry. But if you look at the complete response rate, it was about less than 6% in the pembrolizumab group plus axitinib, but it's only about 2% in the sunitinib group. And then when we compare the toxicities between these two groups, they are actually quite similar. However, please note that in the pembro plus axitinib group, 26% of patients actually had continuation of therapy due to toxicities, as compared to only 10% in the sunitinib group. And then we will quickly go through the other phase 3 trial, Javelin 101 with axitinib plus avelumab. Again, the randomization are very similar. This is the progression-free survival in the PD-L1 positive group and in all patient population. As you can tell, the PFS for for the combination group was 14 months as compared to 7 months in the sunitinib group. And so for all the patients, it was also very similar. The combination group has a PFS of 14 months versus 8 months in the sunitinib group. When we look at the response rate, so in the PD-L1 positive group, the response rate for the combination therapy was 55% versus 26% in the monotherapy group. And when we look at the overall population, the response rate was 51% for the combination group and 26% for the monotherapy group. Again, we have to look at complete response rate. It was 4% for the combination group and for the PD-L1 positive group in the combination group. So, but only 3% in the combination group in the general population. In the sunitinib group, it stays at 2%. Again, the toxicities for the two groups are actually very similar to each other, whereas the avelumab group has some, like hepatobiliary toxicity and also a little bit higher hypertension as compared to the monotherapy group. So here is a summary and a comparison of all the study data. So as far as PFS, they are very similar to each other. Overall response rate, nivo plus EP is slightly lower than the two other combination trial. However, nivo plus EP actually give much higher complete response rate as compared to the two combination groups. So here are my thoughts on IO and IO combination. It looks like IO and IO combination is different than IO plus anti-VEGF because the ability of IO plus IO to produce treatment-free survival rate. And this might be beneficial and provide potential for cure. And so combination therapy that improve median overall survival, median progression-free survival, and median overall survival without producing treatment-free survival may sacrifice the potential of IO and contribute to toxicity, inconvenience to patients, and above all, in addition, drive up the cost. So if we choose a combination, if we do this combination together, this combination should be superior to sequential therapy. For the IO plus VEGF TKI combination, it's unclear whether the activity is synergistic or merely additive. So in addition to that, if you factor into expense and also likely toxicity exceeded, it might exceed the sequential approaches, especially in favorable risk patients. And IO benefits may decrease over time in this group, in this two group of patients. So, and also the ability to produce durable treatment-free survival has not been established for these two IO plus TKI groups. So based upon this data, this would be my proposal for decision-making strategy for advanced renal cell carcinoma. So first, if a patient has kidney in place and with low volume of disease, these patients should still go for cytoreductive nephrectomy. Otherwise, if they have resectable metastatic disease, we can consider metastasectomy. If these patients don't belong to either of these groups, for first-line options, I think for intermediate and poor risk groups, we should use IO and IO combination. And for the favorable risk group, we should use IO plus VEGF. And after that, for second-line option, any therapy not used prior can be considered. For third-line therapy, we can consider any therapy not previously used. We can also consider re-challenge with a different IO combination therapy. For example, if somebody was treated with IO TKI combination, now we can consider IO plus IO, and vice versa. For future perspectives, apparently ongoing and future clinical trial will determine optimal combinations and also optimal treatment durations. But there are many challenges that remain. One would be identification of biomarkers for response and resistance to therapy. The second one would be how to manage IO-induced toxicities. And for therapy development, I think the next step will be developing triple combination regimens, such as nivo-ipi plus any novel agents, anti-PD-1, PD-L1 antibody plus TKI plus novel agents, and with the aim to increase complete response rate and also break the cure barrier. It looks like we are on the way to gain more and more complete responders, and these patients basically can be cured in theory. So in the near future, how do we treat among these different regimens? That will be another challenge. So from now on forward, I think the goals of treatment for renal cell carcinoma would be, one, to produce durable CRs in the shortest time as possible, which can lead to cure. Of course, the overall goal is to prolong overall survival and also treatment-free survival. In the meantime, we also have to consider how to improve the quality of life for patients by minimizing adverse events. Also, we need to reduce the duration of therapy. By doing that, we can also reduce the cost for patients. So that's all. Sorry I went over time a little bit. I appreciate your attention, and we'll be very happy to answer any questions.